సౌండ్ రావడం లేదంటున్నా. చూడు సౌండ్ తగ్గించారా ఏమన్నా? కొంచెం 10 minutes ఇక్కడే ఉంది. ఫుల్ ఉంది కదా. So what are the causes for intestinal small bowel perforation? I was asking. చూడు ఇందులో ఏమన్నా మెసేజ్. Yes, tuberculosis. It may be a cause, but it is very rare. Common causes, common diseases of the small bowel. Recently, small bowel is completed for you. So, volvulus. All the conditions which you are mentioning are possible, but they are wrong. Peptic ulcer, duodenum. No. By small bowel, I mean only that portion which is devoid of duodenum. Inflammatory bowel. No. All are not correct. So the two common causes of corrosive injury, no, paralytic ileum, no, all of them are wrong. So I will tell you the causes. So the share ఇది ఇది పెడితే ఫుల్ స్క్రీన్ పెడితే ఇది రావటం లేదు. అవును, అక్కడ చేస్తే వీఆర్ నాట్ గెటింగ్ దట్. ఇది ఇప్పుడు వచ్చింది, మొన్న ఇందాక రాలేదు. ఓకే, సో ది టూ కామన్ కాజెస్ ఆర్ so these are the two common causes, that is trauma and typhoid. Typhoid, of course, because I wanted to just please 1 minute. Hello. నేను 12 వరకు క్లాస్ So trauma and typhoid, these are the two causes of small bowel perforation, right? Now next is large bowel perforation. Large bowel is also again trauma, and very rarely all the conditions which you have shown or written just now, like inflammatory bowel disease, all those things can cause large bowel perforation. Then rectum also, some portion is inside the peritoneal cavity. That portion also is considered as hollow viscous perforation. Then esophagus, so, and Meckel's diverticulum. So the three main causes of perforation are inflammation, trauma, malignancy. So inflammation for upper GI, it is peptic ulcer inflammation. For lower GI, it is infections like bacterial infections like typhoid, tuberculosis, as already mentioned. Okay, so these are the causes. First, they will ask you in the question, what are the causes of hollow viscous perforation, and write in detail about perforation of the duodenum. So you should write all these conditions gastroduodenal, appendicular, small bowel, large bowel, intra-abdominal portion of the rectum, esophagus, Meckel's diverticle. This is the order. Okay. First commonest, next least common. So then let us go to the perforated peptic ulcer. So in spite of the incidence coming down of peptic ulcer, the incidence of peptic perforation has not decreased. It is still same. What is the main reason? Increased use of NSAIDs, like say diclofenac, aspirin, all these things. And this peptic ulcer will form, as I already shown you, 35% of hollow viscous perforations. And naturally, men who are more involved in all sorts of things, they are mainly affected. Okay. Of deep peptic perforations, duodenum again is the commonest, 65 to 75%. So, of all the hollow viscous perforations, duodenum is the commonest. Then pylorus, then stoma. Stomal sometimes can perforate, rarely, mainly due to malignancy. Okay. So these are the causes. Now let us go to the perforated duodenal ulcer. Again, this is more common in males, 10 times more common. And the age is, common age is 30 to 40. And both acute and chronic ulcers can perforate. Chronic ulcers, 5% of chronic ulcers will perforate. But 50% of them will give you the history of chronic duodenal ulcer. And there is concomitant use of NSAIDs, steroids, and alcohol is another cause. As I already told you, anterior ulcers are more common to perforate, as I told you, because there is no support for them. Only after cirrhosis it's all open. So, and these cases will have a mortality rate of 10%. That means lesser than the gastric ulcer perforations. Okay. So, what are the clinical features of a perforated duodenal ulcer? There will be pain. This pain is sudden, severe, and persistent. First, it will be naturally felt in the epigastrium, and later it becomes generalized. As the peritoneum peritonitis will become generalized, the pain will also naturally become generalized. Fever. So, regarding temperature, 3 phases will occur. First, with the shock, and there is some neurogenic and hypovolemic shock. So first temperature will be first in the initial phases there is decreased temperature. Initial. Then there will be increased with bacterial peritonitis. Finally, when there is septic shock, there is subnormal temperature. So all of you know that septic shock in decompensated phase, that is late stages of septic shock, there will be subnormal temperature. So fever, if it is there, means it is in the middle stages. Vomiting, usually it may not occur. So, but it is one of the features, but usually we exclude perforation if there is vomiting. We will think of intestinal obstruction if there is vomiting. Oliguria, all of you know, is because of hypovolemic and finally septic shock. The patient to look at is toxic and there is shock as manifested by tachycardia, hypotension and tachypnea. Okay. Then on palpation of the abdomen, there will be tenderness and rebound tenderness. This is so-called Bloomberg sign. What is this rebound tenderness? Rebound tenderness. Tenderness everybody knows. It is the pain felt on palpation. Tenderness. What is rebound tenderness? Yes, rebound tenderness. Pain felt on removing pressure. Very good. Not actually pressure on. Okay, to some extent you are correct. So that is the, as you palpate, if you patient feels pain, that is called as tenderness. If you remove the hand because of the sudden wave of pressure onto the parietal peritoneum, on removing the hand, the patient will feel, because parietal peritoneum is more sensitive compared to visceral peritoneum. So that is called as rebound tenderness. That is the so-called Bloomberg sign. Then there will be guarding, that is muscle guarding will be there, voluntary and rigidity. This is involuntary muscle spasm, so-called board-like rigidity. This is very characteristic of duodenal perforation or any hollow viscous perforation with generalized peritonitis. Patient will have board-like rigidity. What is this board-like rigidity? See here, abdomen is the both recti have contracted, and if you feel it, the abdominal wall will be like a board, cardboard. Usually we call it cardboard-like rigidity. Okay. Then if you percuss after palpation, if you percuss, there is obliteration of liver dullness. Usually we hear obliteration of this liver dullness in the 5th to 7th or below. Whereas in the case of perforation, because of this pneumoperitoneum, as all of you know, the air will reach upper areas because of light weight. So the subphrenic space on the right side above the liver, the air will occupy on perforation of a hollow viscus. The whole air in the lumen will come out. So there is liver dullness obliteration on percussion. And the abdomen is still, and if you auscultate, it is silent. So abdomen, as you can see here, it is still. Patient, if he moves, there will be more pain. So abdomen will be still and silent because of ileus. Now gradually there will be abdominal distension also. So these are the various features. So symptoms are pain in the epigastrium, which is very sudden, severe and persistent. Fever may develop. Patient will become toxic and he is in shock. There is tenderness, rebound tenderness, guarding, rigidity, obliteration of liver dullness, and the abdomen is still and silent. Gradually there will be distension. So this is already I have shown you the board-like rigidity. Now there are stages of peritonitis, particularly in duodenal or gastric peritonitis, perforation. That is because on perforation there is release of acid. So what will happen is, first there is what is called a stage of chemical peritonitis. So the whole acid will reach the peritoneal cavity and then induce inflammation. That is called as chemical peritonitis. This may last for 1 or 2 hours. Naturally, the peritoneum will react. So this is called a stage of reaction or stage of dilution. Why dilution? Because as a reaction, what the peritoneum does is it will secrete more peritoneal fluid. So naturally the acid will get diluted. So that's why it is called as stage of dilution. But it's also called as stage of illusion. Why it is called as stage of illusion? Can you tell me? Why it is called as stage of illusion? Dilution, okay. Stage of reaction is also okay. But why illusion? Illusion to whom? I hope you know the meaning of illusion. Recently, I heard that you are hearing classes of psychiatry. So you must be knowing the meaning of illusion. Not able to know. Feeling of neutralization of acid. Patient doesn't know that there is acid inside his peritoneal cavity. False perception. What is that false perception? I am asking. By neutralization of acid, what will happen? Because of acid, there is peritonitis, chemical peritonitis. Once it is diluted, what will happen? You are correct partially, but you should explain more in detail. Anyhow, it is the pain will ease a bit because of dilution. Pain will ease a bit. So the patient is under illusion that is now normal. That's why in this stage, patient may not report. So he thinks that the common history he will give you once he lands in hospital is, sir, there was pain first, later it is completely relieved of pain. So that's why it didn't bother. But what happens ultimately is there is bacterial peritonitis. Where from these bacteria are coming? You know that the stomach, because of acid, it doesn't contain any bacteria. So through the perforation, no bacteria will escape. But how come there is bacterial peritonitis here? I think I have answered this question long back. I hope you remember. Where from these bacteria are coming into the peritoneal cavity? I have almost gave you a tip. Yeah. Intestinal flora, how they are coming? Intestinal flora is only E. coli usually, or any other bacteria for that matter. But how come it is coming? Through what it is coming? You are correct. Intestinal flora only, not from outside. Because the perforation is not exposed to outside. It's within the peritoneal cavity only. But from how it is coming into the peritoneal cavity from the lumen of the intestine. Perforation of, so there is no associated perforation. That's what I am telling. perforation of the stomach, not perforation of the intestine. Bacterial peritonitis is there in the peritoneal cavity after duodenal perforation. I can expect after intestine perforation, peritonitis, bacterial peritonitis. But how come I am giving you a tip also, the bacteria are coming from intestine only into the peritoneal cavity. How they are coming? I told you, but you forgot, maybe in your other subjects concentration. So, as I write, you will remember. So it is translocation. In peritonitis, there is increased permeability. So, translocation of bacteria from the intestine to the peritoneal cavity. So that's why there is what is called as stage of bacterial peritonitis. So usually this takes about 6 to 8 hours after perforation. So initially there is chemical peritonitis with severe pain. Then there is a bit of easing. Then again, once the bacterial peritonitis sets in, patient will have a diffuse peritonitis features. All the features which I have described, like tenderness, rebound tenderness, then the silent, still abdomen, all these features, and ultimately leading to the distension of abdomen will occur. So once this picture, patient comes with these features and there is shock and toxic. So immediately if you suspect a perforation, what you have to do is take erect chest or abdomen. Usually because the patient may not be able to stand, it's enough if you take a chest X-ray and sitting position. So that will show you free gas under diaphragm, usually right dome of diaphragm. Why not you see on the left side? Why I am specifically telling right side? What is there on the left side? I have answered also the question almost. Yeah. Liver. Liver is there on the left side. Why you have to see on the right side? My question is, why you have to see on the right side? Why not on left side? Why not on left side? Why I am specifically telling on right side you have to see for this pneumoperitoneum. Yes. What is there on the left side? Containing gas. Usually in a chest X-ray, you will see like this. So you will see a fundy gas shadow like this. So this is the fundy gas shadow. Will be black. Whereas here there is liver that is white. So this is all black, this is all white, liver. So the air will reach mainly the right side because duodenum is here, isn't it? Duodenum is here, so the air will reach like this. So there will be gas on the right side. Left side also, if it is seen, means it is huge perforation. So I will show you on the left side also. Yeah, fundus of stomach on left side, good, correct. So I will show you actual pneumoperitoneum. See this? Of course, in this you are not able to see the fundic gas shadow, but there you are clearly seeing the pneumoperitoneum, which is, what is the shape? It is semi-circular, like this. So that is the pneumoperitoneum. Okay. So immediately you have to take chest X-ray or abdominal X-ray, plain, erect posture. That is very, very important. Erect. You can see free gas under diaphragm. Of late, we are regularly doing ultrasound abdomen also. So you will see not only gas, even free fluid also you can see. To diagnose perforation, hollow viscous perforation, CT scan is rarely used. If at all you want to use it, it is mainly for confirmation or to rule out other conditions. The commonest or closest diagnosis is usually acute pancreatitis, because the pain will match acute pancreatitis. Duodenal perforation pain and acute pancreatitis pain will match same. So if at all you want to do CT scan, you have to do it for confirmation or to rule out other conditions. Similarly, rarely we may be able to do serum amylase also, but I think I have told you that one of the reasons for raised serum amylase is not only pancreatitis, it may be duodenal perforation also, though not to the same extent. So it has to rise 3 to 4 fold for you to think of acute pancreatitis. Whereas in duodenal perforation, it may rise twice the level, normal level. So usually the investigation of choice is erect chest or abdomen, but confirmatory is CT scan. Please don't get confused. The role of erect chest and CT scan. In entrance, they may try to confuse you. Investigation of choice is not CT scan. Investigation of choice is erect chest or abdomen, whereas confirmatory is CT scan. That is the difference. Now let us go to the differential diagnosis of acute duodenal perforation. So naturally, acute appendicitis. Already I told you one of the incidents where this duodenal perforation can mimic acute appendicitis. How come? Can anybody tell me? How can a duodenal perforation can mimic acute appendicitis? In fact, one of my classmates has called me for surgery. He said it is only appendectomy. I usually see the patient before putting my knife. So I have seen this patient and I felt cardboard-like rigidity. I said, please do X-ray chest. He said it is unnecessary. I insisted. He was so adamant that I had to tell him that if it is acute appendicitis, I will do it free. Then he relented and he has taken X-ray chest, and to his dismay, he has seen gas under diaphragm. Of course, appendix can rarely, very rarely produce pneumoperitoneum, but the commonest cause of pneumoperitoneum is acute duodenal perforation. So now, can anybody tell me how duodenal perforation case can mimic acute appendicitis. You know you must be knowing the symptoms of acute appendicitis. So, yes, yeah, very good. So, 7148, very good. Fluid collected in the right iliac fossa, very nice. So, right paracolic gutter, the fluid will reach the, so like this. So the fluid will reach from here, will reach here and then cause local peritonitis or reaction. And then it will result in symptoms similar to acute appendicitis. So that is the answer. So right paracolic gutter collection of fluid, correct. So now let us go back to our presentation. So one of the differential diagnosis is acute appendicitis. The pain itself in the epigastrium will if the patient is alcoholic and obese, you have to think of acute pancreatitis. And a patient of cholecystitis, now previously if it were to be a female, we used to diagnose cholecystitis. Now both males and females both are having cholelithiasis and cholecystitis. So this is one of the frequent diagnosis, cholecystitis. But peculiarly see these two conditions, medical conditions: myocardial infarction or pneumonia. So the pain is such a severe nature that you may think of myocardial infarction also. And the patient's sweating will also lead you to think of, because all of you are interested in heart rather than the stomach. So first you think of myocardial infarction and the patient gets delayed treatment. So don't make that mistake. You can take ECG, of course. No harm in taking ECG, but you have to be very careful. Even in myocardial infarction, there is rise in serum amylase. That is another problem. So all these three conditions are closely mimic perforation, pancreatitis, myocardial infarction. Then pneumonia, of course, because right lower chest pneumonia patient, you may think of perforation also, or vice versa. So this is the differential diagnosis. So already I have shown you the pneumoperitoneum. Now coming to the treatment of duodenal perforation. So the treatment is ultimately surgery, but first you have to institute conservative treatment. Already I told you, if you don't know anything, you simply write Rayleigh tube aspiration and nil oral IV fluids. All these things you are very sure, isn't it? So if you write this, half of your answer is correct. So nil per oral, Rayleigh tube aspiration, IV fluids, Foley's catheter for maintaining fluid balance, fluid chart you have to maintain. So output, urinary output you have to measure. Then analgesia, you can give some narcotic analgesic. Now all the drugs are not available. Previously we used to give morphine, later pethidine, then we have switched out to pentoxicane. Even that is not available. So now the role of analgesia is mainly now limited to the anesthetist rather than the surgeon. So we institute all these things, and then antibiotics you have to start, because already I told you it will land in bacterial peritonitis. So you have to give some broad spectrum antibiotic like cephalosporin 3rd generation. Usually nowadays we give ceftriaxone sodium. Okay, loading dose we will give. Then ultimately the treatment of perforation is surgery alone. So what is it? You have to do laparotomy by what is called as upper midline. This upper is in relation to the umbilicus. So this is umbilicus. So you have to give incision like this. So this is the upper midline incision. So laparotomy you have to do. Then the most important step is not closure of perforation, mind you. Most important step of surgery is thorough peritoneal toilet. So you have to use about 3 to 4 liters of 3 to 4 liters of saline or ringer lactate. After thorough suction of the pus, you have to irrigate the peritoneal cavity with 3 to 4 liters of saline, and then again aspirate it, and ultimately the treatment is closure of the perforation with silk sutures, usually either 20 or 30 silk we use. 2 or 30 silk. You have to use 2 or 30 silk, and before tying the knots you have to put omental patch, that is called as so-called modified Graham's patch. So the omentum is here only. So here you can see that this is the perforation and this is the colon. Okay. So the omentum is like this. This is the omentum. Now you have to bring a tongue of omentum like this. Like this, you have to bring a tongue of omentum anteriorly like this. Over the perforation. So this is the perforation. Over it, you have to bring the omentum like this, and then suture. 3 sutures you have to apply. So that's how you have to tie the knots over the peritoneum, over the omentum. That's how you have to do it. Okay. So ultimately, what you have to do is, this is called as Graham's, modified Graham's. Graham's means only you have to cut the omentum like this. A piece of omentum you have to put. Whereas now we don't do like that. We put a continuous tongue-like thing we will bring. So that's why it is called as modified Graham's. Ultimately, you have to put a drain, tube drain you have to put, so that whatever is there inside the peritoneal cavity can come out. So there is controversy now regarding the placement of drain, but still we are using it. The whole procedure can now be done by laparoscopic surgery. By laparoscopic surgery, this is very easy. Thorough peritoneal toilet is very easy by laparoscopic surgery, because you can suck each drop of pus, and then you can irrigate each corner of the peritoneal cavity. So laparoscopic surgery is now gaining in treatment of perforation. Of course, after surgery, once the patient is discharged, you should not lose the follow-up. You should do endoscopy after say 6 weeks and then institute eradication therapy because the ulcer can recur and even it can re-perforate. So usually the follow-up is endoscopy, eradication therapy. So that's about acute duodenal perforation. Now let us go to, so this is the Graham's patch. See 3 stitches and then this is the tongue of omentum. It is not picturesque because omentum will be from here, not from here. So even books also, textbooks also represent wrongly. So whatever it is, this is how we have to bring the momentum here and then place it. Okay. Then going to the perforated gastric ulcer, only thing is treatment is same, but you have to take a bit for biopsy because you have to rule out malignancy. So malignancy to be ruled out. Here the mortality is double, 20%. Stromal ulcer is also there. There is another entity called as sealed perforation. By the time the patient comes to you, already the perforation is sealed. Naturally, by the body itself, by momentum itself, or the lesser momentum is there, that will seal it. So that will come as a subacute presentation, and if you suspect subacute and the patient is comfortable, you need not do surgery. So simply observe the patient, treat him conservatively, institute rinse tube, IV fluids, the oral antibiotic, and if he recovers, all right. Otherwise, you have to again open the abdomen. So that's what you have to do. So that's about other ulcers. Now let us go to another complication, that is hematemesis and melena. This is also an essay question for you. So what are the causes of hematemesis? They ask you, don't confuse this with hemoptysis. So in surgery, don't write the conditions, lung conditions. Hematemesis. Hematemesis is vomiting of blood, and melena. He may not give melena, but he may give you as what are the causes of hematemesis. And an easy examiner will give you like this. What are the causes of upper gastrointestinal hemorrhage? They may ask. So this is the list of causes of upper gastrointestinal hemorrhage. What are they? Ulcers. 60% of hematemesis cases are due to ulcers. 26% are due to erosions. Then you have other varieties. Already we have talked about the Mallory-Weiss tear in the esophagus. Then esophageal varices, tumors rarely 0.5%, vascular lesions 0.5%, and all other miscellaneous conditions 5%. Now let us go back to the 60% ulcers, of which 6% are due to esophageal ulcers. Gastric ulcers form 21%, whereas duodenal ulcers 33%. So both perforations and hematemesis, it is the duodenum that is the commonest source. Okay, that you have to remember. So overall, 33% of hematemesis cases are due to duodenal ulcers. Usually either acute due to drug-induced or chronic due to peptic ulcer. Of course, erosions also same, esophageal, gastric, duodenal. But you have to concentrate here, duodenal 33%. So this is the list of causes of upper GI hemorrhage or hematemesis. Now, what do we call the lower GI hemorrhage? Definitely not hematemesis, isn't it? What do we call it? Lower GI hemorrhage. See, upper GI hemorrhage, usually because of acid, the color will be what color? In upper GI hemorrhage, upper GI hemorrhage, particularly stomach, if it is not very large or huge amounts, what will be the color? Because I'm giving you the, yeah, coffee ground, very good, brown, very nice. So it is either coffee ground or brown, but unless there is coffee color, I will not diagnose upper GA hemorrhage is also wrong. Because if it is, let us say, gastroduodenal artery erosion and then bleeding, it is very huge and then it will be bright red only. But usually, upper GA hemorrhage, if it is less, it is coffee ground color. Whereas lower GI, it will be what color? Let us say recently you have finished Meckel's diverticulum. So what is the color of bleeding? Meckel's diverticulum. One of the important topics is Meckel's diverticulum for you. Recently, I believe, last Friday you heard about Meckel's diverticulum. So what is the color of bleeding? One of the complications of Meckel's diverticulum is bleeding. What is the color? So that means you are not concentrating on these classes. Even my class, I doubt very much. So usually lower GI is bright red or a bit altered, but it is red only. Then can anybody tell me what is hematochezia? Hematochezia. I will write you the spelling for your convenience. Hematochezia. What is it? Blood in stools. Yeah. Bright red stool. Yeah, very good. Blood in stools. Correct. So most of the lower after sigmoid, so sigmoid or rectum, anorectal conditions will lead to passage of, yeah, blood for stools or ants. Yeah, that is hematochezia. So different regions, different. So by the color itself, you can diagnose the source of bleeding. So if it is coffee ground, it is upper GI. If it is altered red, it is lower GI. And if it is bright red, it is hematochezia, still lower, anorectum or sigmoid or rectum. But there is another condition that is called as, that is described as red current. What is this current? Can anybody tell me? Red currant jelly stools. Where do we see this? Red currant jelly stools. Can anybody tell me where you can see red currant jelly stools? Yes, interception, very good. So interception, you will see red currant jelly stools. Very nice. What is this current then? Red current. That means there is another color current also. Not our current means electricity here. What is this current? Black current is there. What is this current? So current is a fruit, right? Right. Now let us go back to our topic. So duodenal ulcers. Now, for any hematemesis or for any bleeding or hemorrhage, the principles are same. First thing is that is you have to resuscitate the patient first. Whatever may be the cause. I've given you a list of causes, but for all the causes, treatment of resuscitation is same. Immediately you have to get an IV access. This IV should be thick needle, not a thin 22 needle. Either 18 or 16 needle. You have to put IV access. CVP monitoring if the bleeding is huge. Again, catheterization for input-output chart maintenance. Blood you have to send for cross-matching. And reserve blood because transfusion is needed if there is loss of more than 30% of blood volume. Normal blood volume, you must be knowing, is about 5 liters. So, if it is more than 1.5 liter loss, you have to immediately replenish it with blood. Meanwhile, you can give some colloid or some IV fluids rapidly. Then, once the patient is stabilized, you have to, suppose he comes today, tomorrow morning, early morning, you have to investigate him by doing what is called as upper GI endoscopy. So upper GI endoscopy, you can do it the next day. It is so called as elective emergency. So planned emergency, upper GI endoscopy. Of course, there is Rockall score that I think is not necessary for you. Whereas, so let us now go to the, once you do upper GI endoscopy, you will know the source. So we'll concentrate today on bleeding peptic ulcers. Okay. So what are the causes of bleeding peptic ulcers? Mainly it is NSAIDs and some use steroids. And in old days, because the vessels are so friable, they may bleed just spontaneously. Then if the patient is on anticoagulants like the aspirin or even the heparin substitutes. So these are the conditions or these are the causes of bleeding peptic ulcers. Of course, this will be hastened with the comorbid conditions also. So another problem is high mortality. 20 to 30% of these people will succumb. So on endoscopy, of course, this is not for your theory, but for in entrance, they may give you this forest classification on endoscopy. On endoscopy, what is the picture? If the bleeding vessel is there, spurting blood, that is 1A. So actual bleeding you are seeing, that is the vessel arterial bleeding you are seeing, that is 1A. If there is just oozing of blood, it is called as 1B stage or class. If you can see a vessel there, then it is 2A. Instead of vessel, already there is a clot, it is 2B. If you see only ulcer, nothing else, clean ulcer, that is class 3. So, depending upon the severity, it is classified. Forest classification, this you can remember for entrance purpose. If you write in exam also, you will get more marks. If you can remember, that is well and good. So 1A is spurting vessel, 1B is active bleeding, 2A is visible vessel but not bleeding, 2B is already it is clotted. 3 is clean ulcer. So this is forest classification, right? Now let us go to bleeding duodenal ulcer. So 10% of ulcers bleed. That means this is the commonest complication of a duodenal ulcer because perforation is 5%, whereas 10% of ulcers will bleed. And as already we have stressed, posterior ulcers because there is gastroduodenal artery that can bleed, and if it is gastroduodenal, it will be very severe. Again, same thing, institute IV fluids, give PPI because it is acid induced. You have to give PPI. Then tranexamic acid also temporarily can arrest bleeding or it can hasten the clotting. So tranexamic acid. And to know the extent of bleeding and also to clear the stomach, you have to put in Ryle's tube. And then not only Ryle's tube institution and aspiration, you have to give what is called a stomach wash with the saline. But this saline, you can put a drop of adrenaline in a concentration of 1/8 to 1 lakh or 2 lakhs adrenaline you can put. So then after endoscopy, you will know whether it can be cured with endoscopy. So endoscopically also you can cautery that area, apply some heat, or by laser you can close it, or there is what is called as a hemoclip that you can apply, and some people inject sclerosant like sodium tetraethyl or phenol in almond. So many are there, so they can be injected. So this is endoscopic treatment. Usually if it is mild or say class 2, these can be done. Whereas class 1, you have to go for surgery, or if there is an expert available, that is interventional radiologist. What he does, he will selectively catheterize this gastroduodenal artery and then inject embolizing material. It may be either chemical or in the form of physical, like the globules, they can, or springs, coils, anything can be injected into the vessel so that you can block that vessel. So that is called as angiographic embolization of gastroduodenal artery. So these are all the conservative methods. Institution of IV fluids, Ryle's tube, PPI, tranexamic acid, stomach wash with adrenaline, diluted adrenaline, endoscopic methods, angiographic embolization. These are all conservative. Whereas surgery, if the patient is not relieved or there is recurrent hemorrhage, patient is deteriorating, then you have to do immediate surgery. Again, same thing, supraumbilical midline incision only. You have to give vertical midline incision. Immediately you have to identify the pylorus and duodenum. So you have to give a longitudinal incision. So this is the stomach and duodenum. So gastroduodenal artery is here, it is bleeding. So what you have to give is a vertical or this longitudinal, we call it, we don't call it vertical. So longitudinal incision, open it like this. I will draw a bigger one. So open it like this. Okay. So open it like this. Identify the bleeding point and put a figure of 8 stitch. Figure of 8 stitch. Close it. Then you should not suture like this back. Your suturing should be like this. This end should go here. That means you are suturing vertically like this. So that this is a bit of pyloroplasty you are doing. So the stomach and duodenum will become like this now. So like this you have to suture. Longitudinal incision sutured vertically. So the stomach and duodenum will be widened. And incidentally, if the condition of the patient is good, you may even do vagotomy and also. So truncal vagotomy you can do. So it is underrunning of the bleeding vessel. This is very, very important word. Remember, underrunning. And another word you have to remember is figure of 8. These two are very important. And you are doing Finnish pyloroplasty. That's what I have drawn there. So the longitudinal incision is closed vertically. And you can do truncal vagotomy also if the patient is fit. There are other conditions like Delphi's disease. This is an arteriovenous malformation. Here, the mucosa is normal. It is submucosal. You may not see the lesion unless it bleeds. So, usually, not finding any source, what we do is we will remove the stomach, gastrectomy. Then pathologist will tell you that it is a Delphi's disease. Another condition is aortoenteric fistula. This is also not important for you. You simply remember duodenal bleeding, duodenal ulcer, right? So this is the second complication of gastric or peptic ulcer. Then let us go to the third complication, that is gastric outlet obstruction. This is least common. So first common I told you is bleeding, second is perforation, third is outlet obstruction. This is called as gastric outlet obstruction. So the commonest cause earlier used to be a chronic duodenal ulcer with stenosis. This is the most common, but it was earlier. And it used to be called as pyloric stenosis also. It's a misnomer because it is the duodenum that is stenosed, not the pylorus. But people used to call it as pyloric stenosis. Now, the commonest cause of gastric outlet obstruction now is malignancy because of carcinoma of the stomach. Okay. So whatever may be the cause, the features are almost same. So if you are given an essay, what are the causes of gastric outlet obstruction? You have to write chronic duodenal ulcer, chronic gastric ulcer, then carcinoma of the stomach, and there are some other conditions like adult pyloric stenosis and duodenal web. So these are the 5 causes which you have to remember. Now let us go to the clinical features of chronic duodenal ulcer with stenosis. So the patient may or may not give you history of peptic ulcer. If at all he gives, it is very long history. He may be saying more than 5 years, I am suffering with the peptic ulcer. 5, 10 years like that, 15 years of peptic ulcer. Gradually, the ulcer gets cicatrized and then ultimately becomes stenosed. And another feature is the pain, which is very characteristic of duodenal ulcer. And it is in the duodenal ulcer, we have said that there is periodicity. That means the patient will have alternate symptoms. That is, few months he will have pain, few months he may not have pain. Though his ulcer is still active, he may not have pain. That is called as periodicity. Already I told you. But that periodicity is lost in duodenal stenosis. This you have to write in the exam. You have to write periodicity is lost. That means there is continuous pain. Of course, some people peculiarly the pain may completely disappear because he no longer produces more acid. So his vagi stop stimulating the stomach. So there is no more hyperacidity. So his pain peculiarly may disappear. But the most prominent symptom of gastric outlet obstruction is vomiting. What is this vomiting? How does it appear? It is very large. And this is very, very important. Lacks bile. There is no bile if it is gastric outlet obstruction. If it is intestinal obstruction, it is bile. Whereas gastric outlet obstruction, even though it is duodenal ulcer, as you know, the bile duct joins the duodenum. Which part? Duodenum has 4 parts. So which part bile duct joins? Yes, anatomist. Yeah. Second part. Very good. 7016. Nice. So second part of duodenum. Whereas the ulcer is in the first part. So it is stenosed in the first part. So there is no bile in a duodenal stenosis vomiting. So large, lacks bile, and it is foul smelling. Why it is foul smelling? You can see the next sentence. Food taken days earlier, 1 or 2 days earlier food, patient will tell you. Though he is having vomiting, he cannot keep quiet. He goes on taking food that is stored in the stomach for days together and he will vomit. So today is Tuesday, he will say, sir, on Sunday I have taken some curd rice, now it has come out. So that is the thing, history, characteristic history, very typical history the patient will be giving. So these 4 features are very, very important. You have to remember and then write it in the exam and then tell it in the clinicals also. If at all you get a case of duodenal stenosis, you have to say it is large, it lacks bile, very, very important entrance question for you, foul smelling, and food taken days earlier. These 4 features. Naturally, he will be losing weight because nothing is going inside, and because even fluid is also not going, he becomes dehydrated. So the patient on examination is thin built, dehydrated, sunken eyes, and on examination of the abdomen, this is the characteristic inspection finding. Distended stomach with visible gastric peristalsis. Now tell me, from what direction to what direction, from where to where the visible gastric peristalsis will go. I of course draw it, but before I draw, you tell me what is the direction of this visible gastric, because there are 2 other peristalsis. One is visible intestinal, another is the visible colonic peristalsis. Now, how does this visible gastric, common sense? So what is the direction of visible gastric peristalsis? I am not getting answer. This is a spotter. Instant answer you should give for this question, because even in sleep, if you are asked what is the direction of visible gastric ulcer, visible gastric peristalsis, you should be able to tell me. But I am not getting the answer. So sorry. I think I have shown, yeah, from proximal to obstruction. What is proximal? I am asking, that is the only question. Which side is proximal, which side is obstruction? Proximal to obstruction is correct, but from which side to which side? From which area to which area? That is another thing. So there is not much of time. So I will draw the figure at least, then you can tell me. I'm drawing this stomach for the last so many days. Still you are not able to tell me. The stomach is usually dilated. So it is dilated, and there is stenosis here. That is duodenum. So what is this area? This area is left hypochondrium. So left side. From left to right. So this is right hypochondrium. Then in between is epigastrium. And because stomach is dilated, even umbilical region. So from left hypochondrium through the umbilical and epigastric region to the right hypochondrium. That is the direction. So like this. So that is the visible gastric peristalsis. So like this, from left hypochondrium through the umbilicus epigastric region to the right hypogastrium. That is the direction, right? So that is visible gastric peristalsis. Next I have written a succussion splash. What is this succussion splash? Can you tell me what is this suction splash? And what sign it is? Inspection, palpation, percussion, auscultation. Auscultation, yeah. Auscultation is half correct. I will give you points for that. But if you simply shake the patient, you will hear a sound like coconut water. So usually before buying coconut, we usually shake the coconut like this and then hear. That comes under inspection, palpation, or auscultation. We don't use teeth to see coconut, to hear coconut water splashing, isn't it? Right? Anyhow. So suction splash, if because the stomach is full of fluid, if you shake the patient, then there will be, you can hear actually the fluid sound. That is suction splash. Then this is important. Metabolic effects. What are the metabolic effects on after this duodenal stenosis? Because the patient is vomiting acid, what he will be losing? Both HCl means both the hydrogen and chlorine. And gradually even sodium is lost. So to the body, what it does is, it will release potassium and hydrogen instead of sodium. That's why there is very characteristic hypokalemic, hypochloremic, and because acid is last, alkalosis. So this is very, very important. You have to write this, and whenever you are asked also, you have to tell us that it is hypokalemic, hypochloremic alkalosis. Sodium is last, but the body will try to compensate it by retaining sodium in the kidney. So the kidney, what it does, it will release instead of, because all are positive only, all are cations. Both this sodium, potassium and hydrogen are cations, so plus only. So instead of sodium, it will release potassium and hydrogen. So each sodium will have 2 plus. So both potassium 1 plus and hydrogen 1 plus, 2 plus. So that's why what will happen in the urine, instead of the patient of alkalosis, he has aciduria. So that's why it is called as paradoxic aciduria, right? So then in addition to both sodium, potassium, chlorine, hydrogen, the patient will also lose calcium and magnesium. If he loses excess calcium, then it will result in tetany. So hypokalemic, hypochloremic alkalosis with tetany. This is the full picture of duodenal stenosis. Whereas this is the typical feature of duodenal stenosis, it is not seen in all varieties of other causes of gastric outlet obstruction. In fact, in malignancy, it is not prominent. So that feature you have to think of. If the patient is going into this metabolic disorder, think of duodenal stenosis rather than carcinoma of the stomach. Though I told you, nowadays carcinoma of the stomach is becoming leading cause of gastric outlet obstruction, particularly in the West. Even our places also, in rich places, now it is carcinoma stomach rather than the duodenal stenosis, right? So these are the metabolic effects. You have to remember them, by heart them, whatever you do, you should represent them. Hypokalemic, hypochloremic alkalosis with hypocalcemia, hypomagnesemia. So what are the investigations? Naturally, because it is peptic ulcer, you have to go for upper GI endoscopy. But the main purpose is again to rule out carcinoma. Rule out carcinoma. Previously, we used to do barium meal examination, wherein we used to find, even this is kept in exam also, this X-ray. Even now, if we don't have any other X-ray, we'll keep this X-ray for you. So, what is the appearance? Grossly dilated stomach, already shown you. Absent duodenal cap, non-passage of barium into the distal part of the duodenum, and mottled appearance because of the food. So this is the barium meal examination. You can see hugely dilated. The stomach has become J instead of a horizontal C. It has become a J shape. See here, J-shaped stomach, hugely dilated. The duodenal cap is absent here, and it is usually the barium will not go into the distal part. Okay, this is the mottled appearance because of the food, right? And electrolytes you have to do because there will be hypokalemia, hyponatremia, hypochloremia, and you have to do serum calcium also because it can result in tetany. And ECG, of course, you can see if there is a, can you tell me what will be the ECG potentials on in duodenal stenosis because you are losing all these elements. What will be the ECG picture? You are all medicine experts, so you should tell me. I am poor in medicine, so I am asking your advice. ECG appearance with this electrolyte picture. Or how will be the ECG? What changes will be there in ECG? Yeah, short QT one, but more important. More important. More important. I'll give you a tip. There is hypokalemia. So, hypokalemia will result in what? Dominant U wave. More important. What will happen to the potentials? Decreased or increased? By looking at ECG, you can tell this is hypokalemia, this is hyperkalemia. Inversion T wave. No? The potentials are smaller. So, in hypokalemia, the ECG will be like this, whereas in hyperkalemia, like this. That is the difference. Okay. Right. So, ECG we will take, then ultimately treatment. What is the treatment? So, this is what I told you, teapot stomach in gastric ulcer. It's also called as purse string stomach, like a lady's purse. So, that's why this is called as purse string stomach. This is seen in gastric ulcer. Suppose the ulcer is here, ultimately it will become like this, teapot stomach. In the exam, you may get a short notes, 2-mark question, teapot stomach. Then you have to write, it is due to the cicatrized gastric ulcer. It is assumed like this. So the lesser curvature becomes shortened, and that is compensated by the greater curvature. That's why it will assume either a money purse appearance or teapot stomach, right? So what is the management? Again, same thing I told you now. Whenever you don't know the answer, you write nil oral IV fluids, trials tube, you will be half correct. So rehydrated with IV saline, very, very, very important. Don't give dextrose in a stenosis patient. It is saline, saline, saline. That's all. And if there is gross hypokalemia, you have to give potassium also. KCl, you have to supplement. Then peculiarly, there is, because of hemo concentration, HB is high. But that once you give IV fluids, the blood gets diluted and the HB will become normal. That is the actual HB. You will see it will be always around 8 or 9. So you have to give blood also. So again, Ryle's tube and lavage is very, very important because the stomach, by becoming very huge, it will lose this contractility. So it has to regain the contractility. You have to empty it first, then lavage it with saline. Then ultimately the treatment of choice is surgery, that is GJ, that is gastrojejunostomy and vagotomy. So here GJ, usually we will put a stoma of 5 centimeters, but in stenosis we should put bigger or smaller stoma. Usual stoma for duodenal ulcer is 5 centimeters. Here I should put big stoma or smaller stoma. In duodenal stenosis, duodenal ulcer, I will not put big stoma because dumping syndrome. So that is the problem with big stoma. Now you tell me, in duodenal stenosis, how much stoma? It should be larger than 5 or smaller than 5? Common sense only again. Big or small stoma? More than 5 centimeters or less than 5 centimeters? I'm not getting answer. So difficult? Only common sense. I misled you with one point. That's why you are unable to answer. It is, yeah, okay. I don't want to wait further. So it is bigger stoma. Because after contraction, the stomach attains normal size. Your 5 centimeter stoma will become 3 centimeter stoma, and again there is a stenosis sort of picture. So you should put some 7 or 7.5 centimeters, so that ultimately will become either 4.5 or 5 centimeters stoma. So big stoma. So the GJ will be big like this, bigger GJ. And of course, our gastroenterologist colleagues, they don't want to give the case until last. So they will try all sorts of things only to cause perforation, and repeated dilatations will result in more money for the consultant. But ultimately, he has to send it to surgeon. Duodenal stenosis is such a thing that only surgery can relieve, not endoscopic balloon dilatation. Duodenal stent mainly for malignant cases as a palliative, just like you have heard in esophagus, esophageal stent. Duodenal stent is for malignant cases of gastric outlet obstruction. Then there is one variety called as adult pyloric stenosis. Just now, no, earlier I told you have heard a class that is infantile pyloric hypertrophic pyloric stenosis. Similar entity exists in even in adults also, but rare. For those patients, simple pyloroplasty is enough. Whereas for IHPS, it is pylorotomy. Please remember, that is pyloromyotomy. Whereas here it is pyloroplasty. So there is another cause called as pyloric mucosal diaphragm that needs excision. So grossly, the commonest cause for duodenal stenosis, the gastric outlet obstruction, is duodenal stenosis. Treatment is GJ with the vagotomy. Okay, hope I am clear in this. And in the next class, so this is the dilated stomach. You can see how hugely dilated the stomach should be. This much size actually, it has dilated, so huge. Now in the next class, we'll go for the carcinoma of the stomach. Right? Please read that before attending the class so that you can understand better. Right? Okay, any doubts? Any doubts? I told you 3 complications. So you should have at least 3 doubts. Either you have understood fully or you didn't bother to hear the class. These are the only 2 conclusions I can make. Not even a single candidate is having a doubt. Quite peculiar. 1.5 hour class, if you don't have doubts means I have a doubt now. Whether you have heard or not. Girish Ramanama. Subramanian. Girish. So these three are very, very important. You will get essay, short notes, very important topics. Today we have covered. And you will have, in addition to the exam which you are having on this Saturday, an entire stomach you will have after I finish carcinoma stomach in the next class. Again, same 2 hours we'll take. The next, that means after 14 days you will have exam on Tuesday. Today is 30th, no? So next Tuesday, after 14 days, Tuesday, you will have exam on stomach. That is full 2 hours, and half an hour will be for MCQ. Remaining 1.5 hour, you will have exam, theory exam, including essay. So please be prepared for it. This Saturday, you will have exam up to the portion from 21st, 15th to 27th. Okay, 15th to 27th portion covered, both urology, my class, and another class which you are hearing by Dr. Ramesh. We'll have exam on Saturday, that is for 1.5 hours. Okay, right, thank you.